Today I am not physically present at Calcutta to be present throughout the session. So I request Dr. Amit Ghosh, today's moderator, along with our very senior teacher, Dr. Shoman Mondol, Dr. Srinivas, and Dr. Atanu Jana to conduct the today's session so that the students are benefited. And the students, those who are present, they should remember that the bladder cancer is a subject which is now increasing day by day because of the early diagnosis. And for the examination point of view, none of you will be spared if you don't know the bladder cancer basics and the management properly, at least in outline, so that you can deal the most common urological cancer present nowadays, at least this part of the city. With this small introduction, I would like to hand over the today's session to our very eminent urologist of this zone, to Dr. Amit Ghosh. Amita, please take over the session so that I can participate.
Yeah, we are probably another 5 minutes, but I think just introduce the teachers. I think, yes, it is a very important session. Thank you for letting us conduct this. I repeat what I repeat in every session, and I repeat this with passion, that we are here not to actually teach you every little bit of bladder cancer. We are here to play the role so that you can face your exam very well. They are two different, distinct entities completely, independent of each other. Exam does not reflect how much you know about a subject. Exam reflects whether you're a safe doctor and you're a sensible doctor. So we will stick to basics, however stupid it might seem. Basic questions, basic answers, and follow a protocol where you will not fall into trouble. It is extremely important to learn that you must control the examiner rather than the examiner controlling you. If you haven't mastered that art, you're going to fail the exam. Always remember, most cases, at this point of time, you know much more than the examiner. That's an axiomatic truth. There is no point in raising collar saying that, look, this fellow doesn't know anything. You have to concede the fellow opposite you, the senior teacher or the examiner, has got the power to call you a urologist or not call you a urologist. It is very important to appreciate. So you need to satisfy him. We've got with us Professor Deka. Hello, is he here? Dr. Deka.
I don't think Dr. Deka today.
I think Dr. Deka has actually. Yes, I think he has. No.
No. He's not there.
Dr. Deka was there. Yes, Dr. Deka is here.
Dr. Deka, are you here, sir?
Yes, Dr. Deka has tuned in. So I think we must either ring him or ask him to give his introduction so that we can start the session, because we don't want an interruption in between. Dr. Deka, are you there? You've tuned in. Anyway,
please contact Dr. Deka in 1 minute time. If he cannot, then Dr.
Yes.
Ghosh will contact.
I introduce Dr. Srinivas Narayan. Srinivas, very senior urologist in town now, has taken over most of the urology work from us. So he is the icon now. Dr. Professor Shoman Mondal, are you here?
He is joining, sir. He is joining, sir.
And Dr. Atanu Jana. There is Dr. Deka. Dr. Deka, good morning. Dr. Deka, good morning. Dr. Deka, can you hear us? Dr. Deka, can you hear us? Dr. Deka, can you hear us?
Yes, good morning.
Good morning, good morning.
Yeah,
we are very fortunate to have you here today. We are going to start with your permission, but we want some words of encouragement to the students from you.
Yeah, good morning to everybody. Actually, yesterday I could not be present. I am sorry for that. As you know, we had the annual meeting of the Assam Urological Society. So I think the topics that you have selected, excellent topics. All the postgraduate students, MCH and DNB students must know about the topics, the cases you have selected, extremely important. And there is none other than you, Dr. Ghosh, who would do justice for this particular topic. And I hope we will have a very fruitful and good discussion so that the students will be benefited from your deliberations. I think with these words, I request you to start the.
Thank you. Thank you. Thank you for being present today. I think your presence is important. I will take this opportunity to introduce Professor Shomen Mondal. Shomen, you're here. And yes, Shomen. Shomen, can you test yourself? You're on the mute. Yeah. Welcome, Shomen.
Yeah, thank you.
Dr. Atanu Jana, hello. You're muted.
Morning.
Morning, good morning.
Morning.
We've got students, Dilip Kumar. Yes, Dilip Singh.
Yes, good morning, sir.
Good morning, Sachin Patel.
Good morning, sir.
Where are you? Can't hear you. Yeah, okay. Kamal, where is Kamal?
Good morning,
Good morning, good morning. Sandeep Manna.
Yes, sir. Good morning, sir.
Good morning. Ritesh, Vikram and Piyush from yesterday, they are here again.
Yes, sir.
We'll pick and choose. We'll stick to basic rules of the game are we've got a slide share presentation. I promise you, we are going to stick to complete basics. We are here to give you a little training and a feel as to how you should how you should face the Viva exam. The basic principles are that in the Viva exam, it is extremely important to remember that you don't show off your knowledge. You just answer exactly what the examiner wants you to answer, not in monosyllables, but as short a sentence as possible. Try and take control of the examiner. Once you let him loose, you are going to be in deep trouble. Once you've crossed the barrier of basic questions, you've passed the exam. Even then, don't show off. I promise, I've come a long way. I'm 64 years old. I have been in urology for 35 years. I've seen hundreds of examiners. I promise they know less than you. So don't become arrogant because you know more than them. Most of the times, it is your privilege to know more in most cases. That is the rule. But the quality of the examiners are that they're extremely experienced. They know exactly what is important and what is not. This is something you will gain with experience. With that, our first session, we will start with, I'll slide share first of all. I'll ask Srinivas Narayan to take the lead, but I would request the other teachers, Shomen and Atanu, not to go to bed. কোথায় একটা স্ক্রিন দেখতে পাচ্ছি না মানুষগুলোকে দেখতে পাচ্ছি না তো So case 1, a 65-year-old man presents in the OPD with recurrent hematuria. A USG shows a 2 centimeter papillary lesion in the posterior wall of the bladder. Impression, first impression is it's a bladder tumor. There are different sonographies of it. Come on, let us see what is your comment is, and Srinivas, you take on from here.
Who will be answering?
I think Dilip, will you start?
Yes, sir.
Please read this ultrasonography for us.
Sir. This, sir, good morning, sir. This image shows the some space occupying lesions in the bladder, and in first picture, and in second there's a again space occupying lesion in the posterior wall, left posterior wall, with a significant post-wide urine wall, and there is a bladder wall thickness seems to be normal.
Your post-void residue and your bladder thickness, you think is important to comment here? Why did you say so? What is playing in your mind? I agree. Suppose it is very thick, and suppose this is not a post-void residue. What is it?
Since age is 65, maybe accompanying bladder outer obstruction, feature of bladder outer obstruction, along with the patient has hematuria along with the bladder mass.
So you think the prostate could have bled?
Yes,
Yeah.
yes,
You think the prostate could? That's what you're going to tell the patient.
yes,
That you are two sources of bleeding. One is the bladder tumor and one is the prostate. That's what is going through your mind.
in evaluating the hematuria, we have in mind that patient may have the bladder BPH or CA prostate.
That's what Dr. Amit goes.
Remove the clutter of your mind.
Yeah, that's what he was telling me in the beginning itself. You should stick to the basic sort of thing. Now you are going haywire sort of thing. Here there is a bladder with a mass sort of thing. You haven't described the first mass. You went on to second mass. Then you are asking for thick wall bladder, prostatomegaly, whatnot. This mass and this mass, I'm just asking you, but although it is written post-void, that's why you are commenting that it's a post-void. This mass is not posterior. This is a posterolateral sort of thing. And thereafter, you must describe the first ultrasonography.
When you see a sonography, what do you see? This is a bladder tumor. Suppose, before you pass on to the description, now that you've commented that there are two sources, what percentage of prostates present with enlarged prostates present with significant hematuria?
Around 10%.
10%? You've seen that? Or you're quoting a textbook or a paper? And why does it bleed? You've dug your own grave. I didn't ask you for this. You've dug your own grave, so you are going to now give me a statistics of what percentage of patients of prostate bleed, where does it bleed from, and why. Now you're completely off the mark. Srinivas, you take over.
See, dear, that's what I'm telling. Once the history has been told, the patient presented with hematuria, there is an ultrasound finding, you should describe the ultrasound finding. Unless until the prostate is seen in the ultrasound feature, you should not be commenting unnecessarily on prostate and thick wall bladder and whatnot sort of thing. Here there is a posterolateral bladder mass. Here it appears to be arising from the anterior wall, which is more important. You should comment on rather than anything else, because none of the ultrasonography is showing any prostatic impression. So this is an ultrasonography, this is an ultrasonography, although this seems to be different, might be, the same person might be harboring a left posterolateral wall mass along with an anterior bladder wall. So how you are going to deal with this very patient?
You deal with any one of the ultrasounds. There are two different patients. I wanted to give some examples of what it is. You deal with the your left-hand side. Dilip,
Yes, sir.
don't keep quiet in an exam. This is what I meant when I said you take charge of the examiner. Examiner has asked you to describe, you take the easy pathway. It is staring on the face that there is a bladder tumor. So don't deviate. That's the first lesson of this morning.
Yes, sir.
Unless the examiner forces you, you don't deviate what is actually very, very obvious. So now you are dealing with the SOL in the bladder. Please answer your teacher, Srinivasan. He has asked you to tell what your observations are about this. Don't faff around with post-void residues and prostates, etc.
This EOG is showing the mass in the bladder. So I will proceed along for the evaluation of the bladder mass and for the management. And
What further management? You are going to stop on ultrasonography, you will do something else.
I will take a detailed history and examination, sir, and investigate with.
We have told you, stop there, please. We have told you to tell us what you are seeing. So what are you supposed to say? First, let us take the first lesson of this morning. What are you supposed to say from the ultrasound? There are few things instantly should come to your mind. Kamal.
Sir,
come on now, give us a description of this. What do you want to see?
Sir, first in the ultrasound, I have seen a single, the first ultrasound.
Exactly, single. So that's the number. Then?
Then, sir, the size, approximate
size. Okay, approximate size. Then?
Then, sir, its location is located anteriorly.
Exactly.
And then, sir, it is whether it is a broad base or not, it looks
exactly.
Like
so base.
Yeah. And
associated features are not a part of your sonography. Yes, so, Dilip, have you understood? Yes. When you are asked to describe an ultrasound with an obvious bladder mass, you concentrate on the site, size, number, base. Is that clear? Yes. Nobody is going to test whether you know the variant histology of bladder tumor. You've already stuck. You've gone into prostate. You've gone into PVR. You have been brought back by the examiner to the bladder tumor, but you couldn't place your observations right. Srinivas, please.
Do you ask for more films of this ultrasonography, or you are satisfied with whatever is shown to you? What more you want to see on ultrasonography? In an ultrasonography which is showing in bladder mass. Please don't keep quiet, dear.
Sir, morning, sir. Sir, on this is the static film of sonography. It is hyperechoic single lesion with
nothing like dynamic picture of sonography, dear.
Yes, sir. And this is small necrosis also there. So we, I would like to, sir, see that on Doppler there is vascularity is there or not.
Sachin, you are getting into trouble.
Now you are again creating. Should have asked.
You're creating trouble.
What more do you want to know? What about the upper tract?
Yes, sir. Upper tract is also we will see about the bilateral.
Whenever you see a mass in the bladder, you must know what happens in the upper tract.
Yes, sir.
Have you seen the upper tract here?
No, sir. Till now we are.
Sebastian is asking you whether you need any further images. You want to know? Want to see? Ask him.
Sir, I would like to see bilateral upper tract kidney film and hydronephrosis. Any hydronephrosis is there or not?
Anything else? There isn't any. Fine. Anything else you want to see?
We will also look for if any whole abdomen for liver metastasis or anything associated.
My goodness, you think that this SOL is going to metastasize?
No, sir. It is general.
Then what are we talking about? You are going to be a consultant urologist the moment you finish this exam. You are sitting in front of the patient, not the teacher. So you are going to tell the patient that we are going to check whether you've got metastasis. See where you're getting wrong? You're trapping yourself. So please remember the golden words. You direct the examiner in your way. Now you are directing yourself into a ditch. Very clear answer. We will static dynamic film bol ke koi exist nahi karta. Forget about Doppler for the moment. You're exhibiting your knowledge. You don't need your knowledge. Here the examiner needs to know whether you can deliver a safe life for him. You need, Srinivas asked you, will you see other films? You are supposed to say, yes, we will see the upper tracts. We will see any other incidental lesions. Suppose you get a 7-centimeter aortic aneurysm with this, what will you do? So you need to be a doctor as a whole. You're not treating a bladder tumor, you're treating a patient. So you need to know, are you going to look in the ureter? Sachin,
Yes, sir. If
upper tracts means ureter also?
yes, sir. Hydroureteronephrosis is there or not? We
Okay,
will
hydroureter. What else? Do you want to see anything else?
yes, sir. Any associated, any upper tract.
I'm talking about the ureter.
Yes, sir. In ureter, any lesion is there or not? We
You'll be able to see it on ultrasound?
sir, only we can diagnose hydroureter.
Exactly. So you're right. You have to be specific that you can see hydronephrosis, sensitivity of picking up a ureteric tumor by ultrasound is next to impossible.
Yes, sir.
Rivas, please.
So, when you were telling about this color Doppler for your own knowledge, I could tell only in the instances where we are confusing it with the clot sort of thing. Otherwise, we don't do color Doppler routinely sort of thing. And there is nothing like dynamic. Don't utter the word dynamic, static and dynamic in ultrasonography. You will be digging your own grave. What next? See, imagine the patient is in front of you in your chamber and you are dealing with him.
Let's go back to history now. He has come to you, this particular person, I'll tell you the history. He's come and told me that he has come with recurrent hematuria and he has got a sonography. He didn't have to even ask for it. Sonography to panwala mein bhej deta na. Today's day and age, even the panwala tells you to do a sonography and then go. So he's come in with the sonography. We didn't have to order it. So you have got an impression. Now you have started your history. Now, very quickly, time is limited. Who's going to answer?
We will ask detailed history of hematuria. For when was the first episode, and after hematuria is throughout the micturition. Any associated clots, shape of the clots, it is amorphous or what type of clots? Any associated lower urinary tract symptoms is there or not? And any history of any previous intervention in previously, and any history of smoking and any
I wanted it a little bit more methodical. You don't look like a consultant urologist now. We want to make you one by the end of this hour.
Also, we will ask about his comorbid condition also, any diabetic or hypertension is there or not.
So what
And,
will be about
Why do you want to ask about hypertension?
Sir, as a routine history.
Just because somebody's told you, the teachers have taught you have to talk about hypertension. Is that the reason? This is a real exam going on. I'm telling you, this is what you're going to face in the orals. They're going to pick on what you have said. They're not going to pick on what you haven't said. So you started the history very well. You started a history of hematuria. Whether it was the first episode, when did it begin, how often did it happen, is it associated with the whole of the urine, is it associated in the terminal or the terminal part or at the beginning, is it mixed, is it associated with clots, what are the shapes of the clots? You said it, I was very happy with that. Then what happened? Aren't you going to ask them, is he got a painful hematuria or not? Aren't you going to ask them, he's got associated fever or not? Aren't you going to ask them, he's got dysuria, burning sensation or not? So complete your history in a methodical way. So you're with the hematuria and with the urinary symptoms. So first finish the urinary symptoms. Is he been habituated with a prostatic symptoms, which bladder outflow symptoms, where he has got an, what should play in your mind is, what are the pathologies that you're questioning? Then you come to his habit histories. Very important in these. You mentioned it, but with the utmost negligence. In this particular history taking, what you should highlight in order to steer your examiner into your line is tobacco.
Yes, sir.
So emphasize that. I'm going to ask him and, bore him with that. I'm going to ask him how long he has been smoking, how many cigarettes, is it a bidi, is it a soy, is it a cigar? Go on dilating that so that the examiner knows that you know the importance of smoking. That is the art of examination. Now you've kept it in the rubbish bin. Somehow you've mentioned, I'm going to take a history of smoking and then I'm going to take diabetes, hypertension. You don't even know why you're going to ask hypertension. Now tell me, why are you going to ask hypertension?
Because, sir, we will look for patient. We will do management of the patient. So it is.
Hey, forget about management now. I'm still in history. What are you managing?
Sachin, have you asked him about his occupation?
Yeah.
Sir,
Is it
occupational
important?
history is also important, sir.
Is it important?
Yes,
And
sir.
where
No,
from-
let
where
me
from is
finish
coming?
his hypertension. He'll get confused. Let me finish his hypertension. You won't forget this. You will thank me when if you get a bladder tumor in your case. You finish your hypertension. What is in today's day and age a very common cause for hematuria?
What is the common medicine prescribed by an endocrinologist or a cardiologist for hypertension?
Sometimes patient took in cardiac ischemic disease, patient took ecosprin.
Why did you forget that? You started your episode, somebody started the episode with Doppler. I'm asking for simple ecosprin.
Yes, sir.
So don't forget basics. Stick to basics. You will become a urologist. If you don't stick to basics, if you try to teach the examiner your high funda, he's going to make sure that you don't become a urologist. Because then if you're in the market, then he loses practice with your high funda. Carry on, Srinivas, please.
So, Bani, the entire idea was to rule out other causes of hematuria, as Dr. Amit Ghosh was telling. You have asked the history of hypertension just for the sake that you will be ultimately operating the patient. But that's not the right answer. Right answer, we should ask for the blood thinner, ecosprin, clopidogrel, whatever he is taking. From history, occupation, which you missed, is more important, and the amount of BD cigarette, whatever he is using. He's a smoker sort of. So, what next?
Sir, we will.
After the history, what comes?
Sir, after taking history, we will and with USG finding, we will come to.
No. You have just history is completed here.
Dr. Atanu, let him tell. Yeah, tell.
After sir history, we will further take patient's physical examination and local examination and systemic examination. On general examination, we will look for general condition of the patient, pulse, BP, and we will look also for pallor because patient had recurrent hematuria.
Don't give reasons. Go on. Yeah.
Further, we will do sir local examination, per abdominal examination, and we will look for any suprapubic fullness is there, any unibladder is palpable or not. And after that, sir, we will do digital rectal examination to look for prostatomegaly. And after that, we will do sir systemic examination, and we will also look for genital examination.
You have enumerated all examination in a very wrong fashion, sort of thing. Nobody starts with a local examination, then goes to the general examination. It's the other way around, sort of.
General examination I have mentioned, sir.
Yeah, so why you are telling, then you will do a general examination, sort of thing. Yeah, you have to do a quick general examination, and thereafter you proceed to the abdominal examination, and then you should end it. What you are going to see on distal rectal examination, or do you want to do any other maneuver other than this distal rectal examination?
Sir, we will on digital rectal examination first we will look for normal anal tone is there or not. After that, we will see the intrarectal prostatic bulge is there or not. We will do grading according to the size of the prostate, and mucosa. We will see consistency of the prostate. It is hard, any nodule is palpable, any abnormal finding is there, and tender or non-tender we will look for. And sir, we will look for mucosa of the mucosa of the rectum.
Why do you want to look at the mucosa of the rectum?
Sir,
if the bladder will infiltrate the rectum and I'm going to get the mucosa stuck to the rectum and the bladder tumor?
No, sir, for routine examination of digital rectal. Otherwise, we will.
You're wasting your time in the exam.
Yes, sir. If there is no nodule is palpable, then no.
Your answer should be crisp. I will do a rectal examination to see the status of the prostate, and is whether we are dealing with any advanced malignancy of the prostate,
Yes.
of the bladder.
Yes.
Be smart. You're trying to describe it like an undergraduate third-year student.
So the bladder, as shown, is not palpable sort of thing. Distal rectal examination, suppose it's in grade 1 prostate and everything else is normal. What next?
Sir, we have already USG film, so we will do further complete blood counts and serum creatinine and urine culture sensitivity, sir.
Hold on. How do you do culture sensitivity in a patient who is presenting with hematuria?
Sir, first we will see urine routine in urine routine examination. First, we will check regarding blood cells. If at present, if there is clear urine, then we can send for culture.
That's what I'm telling you. No? If you send an entirely hemorrhagic urine sample, the lab is going to return to you.
Yes, sir.
We are not sending an hematuria sample for culture sort of thing. That's
Yes.
not for reasons. You can do only urine routine examination when you are suspicious of something else.
Yes. And sir, a patient had hematuria and we have film, so we can send urine for cytology also, sir.
Okay,
If
cytology.
culture is negative, then sir, we can send for urine for cytology also.
Would you send the urine during hematuria for cytology?
No, sir. After once culture is negative and urine is clear, then we will send for urine for cytology, sir.
With a diagnosed case of urinary bladder SOL in the ultrasonography, is the cytology is necessary?
Sir, if urine cytology is positive, then it shows high-grade urothelial carcinoma. So we can do urine for cytology.
I think it's not going to give you extra information before and preoperatively to do an urine cytology. Urine cytology is done as a part of routine, but high grade will have 60% chances of getting a positive result because it has a very low sensitivity.
Yes, sir.
So
very low sensitivity, particularly in the low grade, specific only for high grade, and particularly in hematuria, you can't do it.
You can't do it.
You agree with this slide? Come on, Sachin. Yeah? Sachin, have you gone off?
Can we ask next candidate?
Yeah. Kamal.
Yes, sir.
Yeah. What is the role of cytology in such patients?
Sir, cytology is mainly, since it is seen, the cytology is more sensitive for high-grade tumor. Also, cytology can be used for surveillance purpose post-treatment, sir. We use cytology mainly there.
That's what Dr. Amit Ghosh was telling you. It is mainly used for a surveillance purpose. It is never used for a diagnostic purpose.
What is the system commonly used for reporting cytology, Kamal?
Sir, Paris system, sir.
So remember this, huh? This is what the Paris system is.
Yes, sir.
Yeah, just for the information, may not be particularly relevant for this particular case, but you know, cytology is a subject that you need to be conversant about as to its role in a case where you are presented with a bladder tumor or a hematuria.
Yes.
Don't make mistakes of suggesting cytology here and there.
Yes.
This is not a very good test, but it is a very good adjunct test with cystoscopy. Any urinary markers you are familiar with? Yeah, sorry, Shauman.
Yeah. If your cytology test reports comes as a positive
Yes.
malignancy, okay,
Yes.
and you have done tumor biopsy in this case, and the report came as low grade T1, low grade. Okay,
sir.
So what will you think? What will you think? What will you do?
Sir, we have to look for other sources of urothelial tumor.
Right.
We have to rule out the upper urinary tract tumor also in these cases. And also we have to look for any prostatic urethral involvement is there or not. And we have to rule out CIS also, sir, by doing random.
Yeah, this should have come first. Come on.
Very good.
This third point should have come out first. Yeah, that's what he was asking for. Anyway, any urinary markers that you would do in this model? Suppose the facilities were there.
Yes, sir. We have urinary markers. Most sensitive is our Eurovision test, sir, where we do the fluorescent in situ arbitration to detect the aneuploidies of chromosome 3, 7, 17, and chromosome 9. We have BTA STAT or BTA track test, nuclear matrix protein test, sir.
Very good. So just to keep it in the background. Yes, Srinivas.
Yeah, the most sensitive and specific is the Eurovision, which is,
yes, sir.
Although it's not available everywhere.
Imaging now. Carry on with imaging now.
Let us go back to imaging.
Yes.
So you have done this where ultrasound has been done and you have seen the things we have discussed about the ultrasound. What next? If the patient is there, recurrent hematuria, 60-year-old with recurrent hematuria, smoker, and you have examined everything else is normal. What you are going to do next?
Sir, I will plan for
investigation. Would you like to? Let me ask you a specific question. Would you like to do any other investigation, radiological investigation, or you will proceed directly to the management?
Sir, it is a broad-based tumor, broad-based sessile tumor. So chances of deep invasion is there. So CT scan will help, sir, sometimes to rule out the muscle invasion if there is present or not.
Now you have gone into CT scan. Let me ask you, give us a specific indication for doing a CT, pre-op CT in case of bladder.
Sir, if there is a presence of hydronephrosis, if there is multiple tumors are there, then tumor size is more than 5 centimeters. In those cases, we basically need to do a CT to CT scan, sir. But here it is not there.
That's the reason why I'm asking you. If it is single, although it is a broad-based tumor, single broad-based tumor, doesn't warrant a contrast enhanced CT scan beforehand. You can do it for staging purposes, but there are specific indication for it. Unless it is a hydronephrosis or it is an extravesical tumor which you can make out on ultrasonography, although very rare, or multifocal tumor, you don't get into CECT beforehand.
Okay.
So it is basically to stage the disease.
Yes.
Get your concept very clear. Don't hesitate. There was a bit of hesitation with you, Kamal.
Yes, sir.
This is a very routine case and a very, very routine questions.
Yes.
And therefore, you should tabulate all these questions and tell the examiner whatever you like. You've given a justification, which the teacher may not agree to. But let us be more rational. In this particular case that we've given, we would always try to do intervene first and do imaging later. But in case you do a CT scan, what is the purpose of the CT scan? This is what the purpose is. Local invasion, lymph nodes, and distant mass. So actually, pronounce these. Don't take it for granted. The examiner knows everything. He has to get out from you. What are you looking at? You're looking at the local. You're looking at the lymph nodes. You're looking at the distant.
Yes.
Very clear answers. That if I do a CT scan, tell them, if you want to you've fallen into trouble, you have to get out of the ditch. Tell them, I have worked with some consultants who routinely do a CT scan. That is the way to get out of your trouble. But I personally, given a chance, I will first manage the patient and do a CT scan later. So you've played both the games.
Yes.
Now the question is, carry on.
The purpose is to stage the disease. In a stage disease, you must have a confirmed histology with a grade sort of thing. From there it starts. An entire treatment modality starts with the biopsy sort of thing. Until you are knowing beforehand that it has gone outside bladder sort of thing, or it has invaded the ureteric orifice leading to hydroureteronephrosis. We tend to avoid this thing, but you can always justify doing a CT beforehand just to stage the disease.
Yes.
You should stick to point what you are telling.
Yes, sir.
Would you ever do an MRI? I mean, the answer is there, but prepare your mind in such a way that if the examiner somehow asks you, will you do an MRI? What is your answer?
So in our setup, we don't do MRI.
The answer is written.
answer is written.
Yes, sir. MRI gives, sir, local invasion. It gives a better idea than CT scan. Nowadays, we have MRI grading also for that. Virus is coming.
No. Stop showing off.
Yes, sir.
No, nobody has asked you that. We have only asked you a simple question. You stop there.
Yes,
What is
sir.
the drawback of doing an MRI? Suppose this patient was having an hydroureter nephrosis on left side.
Yes, sir.
Ask for a contrast in CT scan or MRI.
Sir, if we have CT scan will be better for staging purpose because it will give better idea about the tumor lymph nodal status. MRI is basically better for whether the tumor has invaded the muscle or not. It is better for sir local invasion is there or not.
So your answer should be, it should be contrast enhanced CT scan. Apart from giving a better.
Roger, one thing, for lymph node status, CT and MRI, there is no difference. Okay, for lymph node status, CT and MRI has no difference. Can MRI differentiate between non-invasive and invasive muscle tumor? I mean, muscle invasive tumors?
Yes, sir. MRI has get upper hand than CT scan for differentiating muscle invasion or there or not. Muscle invasion there or not.
Only disadvantage is if there is a concomitant ureteric tumor sort of thing where that CT scan has got an upper hand compared to MRI sort of thing. That's what I discussed yesterday itself.
Very good. Good discussion. Final question, just to complete the circuit of imaging.
Yes.
If a patient demands FDG PET, would you agree? It's fashionable that patients, the class of patients will come in and ask you, Doctor, I want to do a PET CT. What should be your response to that?
Sir, I won't do the PET CT in these patients.
You won't?
I won't do the PET CT, sir.
Why? Reason?
Sir, because information what we already were getting information.
No, that's not the reason. That's not the reason. He's got the money. You don't worry about, forget about it. Suppose you got a free access.
So PET is mainly helpful to
FDG PET. FDG PET is what is commonly done.
Talking about FDG PET.
I'm talking about FDG PET.
FDG PET cannot be, should not be used because, sir, it is a urinary based tumor, sir. It will not delineate anything because the glucose being secreted.
Exactly. So this is the reason. Will it be, suppose he does it. What is the utility of this FDG PET? Suppose he's done it. He's headstrong, he's going to do it. You get such stupid patients, but then what can you do? Big commission, big commissions, so they'll get it done, whether you like it or not. Will it be useful in any way? Come on, this is the answer.
Metastasis, yes.
Okay?
Yes.
If he's committed that sin of doing an FDG PET, it will not help you in the bladder tumor, but it will help you in its metastasis. Now let's now proceed. We've done the imaging. We've taken a history. We've seen the ultrasound. We've seen beyond the bladder ultrasound, what else can be done. We've seen what the role of CT scan is. We've seen what the role of MRI is. We are against doing an FDG PET. Okay? Boys, you are now happy with all this? Now proceed. Now let us get Bikram into the picture. Where is Bikram? Bikram, yes, are you there?
Yes, I am. Yes.
Come on, let me show your please show us your pretty face.
Yes. Good morning.
Yeah. So now what?
So I think all the investigations have already been done. So, sir, I will plan the patient for surgery, which would also include cystoscopy, followed by transurethral resection of bladder.
Very good. Srinivas, carry on.
So,
no, Srinivas, whoever, carry on.
How we are going to plan it?
Sir,
Bikram, where are you? Yeah.
Yes. So,
okay.
So I will ask our anesthesia colleague to evaluate the patient and give his green signal for the surgery. Okay. And then after proper preoperative counseling, I will take the patient to OT. And sir, I will prefer. Are you asking about the surgery procedure, sir?
Yeah.
Yes, sir.
No. First of all, what anesthesia will you give?
That's what I'm going to. You have to request to anesthesia. Most of the time, we do not request to our anesthetists whether they are happy with the spinal or general anesthesia. Here, you have to make a specific request. that I want? What?
Sir, in this case, sir, I would like to prefer a general anesthesia with a deep muscle relaxation for the surgery.
Suppose they are telling that the patient chest is too bad, we cannot give it.
So then, sir, the other options option is spinal anesthesia with bilateral obturator nerve blocks.
Okay.
Without obturator nerve block, can you do the TURBT?
So,
In
sir, it will
spinal
depend on the sir. Yes, sir, it can be done, but sir, it will depend on the location of the patient, particularly the.
No, it's a lateral wall tumor, 2 centimeter lateral wall tumor. Patient is not fit for general anesthesia, and anesthesia says he will only give you the spinal anesthesia. Can you
yes,
do
sir.
TURBT?
Yes, sir, it will be difficult, sir, but sir, there are options like bipolar TURBT or laser, which will reduce the chances of obturator jerk, which can be used in this case.
That is the problem. Not laser or the bipolar. It will not cause the obturator jerk usually. So you have an option. Okay.
Very quickly, you're given 1 minute chance. Breathe out and tell me what is the sort of TURP you're going to do. Is there any variation of TURBTs?
Sir, there are two types. One is piecemeal resection and another is en bloc.
Very
So
good.
this tumor which you have shown in the image in ultrasound was a anterior dome tumor. So, sir, in this case, I will do piecemeal resection. And
What is piecemeal resection? What will you do?
so in piecemeal resection, we first target the exophytic part of the tumor.
Very good. Excellent. Number one. Then
After dissection of the complete dissection of the exophytic part, we take separate biopsy of the deep muscle layer for staging.
thank you. Very good. Number 3. The margin.
Yes, sir.
So piecemeal involves 3 things: the exophytic part, the deep part, and the margin. Okay, so that's the principle. Those are the principles of TURBT.
Even for the posterolateral tumor, the second ultrasonography which was shown, you have to do a deep muscle a piecemeal TURBT because you are not going to get and block specimen in that very case.
When would you have done an en bloc resection?
So in block resection, I would have done in tumors that are smaller than 3 centimeter and that are located in strategically favorable locations like the posterior wall or near the trigone. So in those
Size is important, isn't it? Size. Come on, start with size. Size and site is important. What is the advantage of it?
Sir, there are some theoretical advantages that say as the specimen is taken out en bloc, it will help the pathologist to characterize the tumor and will give us a better staging information of the deeper invasion, whether it's muscle invasive or not in such cases.
Other than this, that is also theoretical sort of thing. Chances of implantation are lesser, what they claim to be, but I don't think so.
Yes. In some cases, they say that the risk of obturator jerk and perforation is also lesser in block resection.
Why it is done with bipolar or this laser one?
So it's complete. Carry on.
So one situation that you have given me, sir, that the patient is not anesthetically fit for a block and block is not given. In that case, those can be used. And also, sir, if
suppose you invited the question. Suppose you are not having the facility of bipolar TURP as well as a laser sort of thing, and you are forced upon to do a surgery in a patient who is under spinal anesthesia. Obturator block has been given, but that has failed. You have seen that it's giving a little jerk sort of thing. What are you going to do? You are inside bladder with your resector.
In that case, sir, I will slow my irrigant flow to half distend the bladder, and I will reduce the current settings to a minimal that is possible for the resection.
Yeah.
Okay, fine. Now enlighten us a little bit about in what cases would you do random biopsies? Have you ever done?
No, sir, I have not done any random biopsy. But sir, in situations where in such a evaluation of such a case, there is evidence of high-grade cytology is positive, or there is suspicion of high-grade tumor, or in cases where the cytology is positive, but we cannot see any tumor while we do a cystoscopy. So in these situations, we take random biopsies.
When would you take a prostatic urethral biopsy?
So in male patient, I would take a prostatic urethral biopsy if there is evidence of tumor located in the prostatic urethral mucosa, or also involving the prostate, and in female, any tumor at the bladder neck. Sorry, not in
Only
female.
on that situation? If the blood, either if the tumor is in the trigone, if the tumor is in the bladder neck.
Yes, sir, in the trigone, bladder neck, and prostatic urethra. In these situations,
If there is CIS changes.
Three things. CIS changes, bladder neck, and the prostatic urethra. So, these are very natural questions which come with any bladder tumor. So you must be very careful.
Where from it will take it?
Sir, prostatic
Exact
urethral.
location?
Sir, if there is evidence of tumor, we'll take the tumor. But if there is no evidence of tumor, then I will take prostatic urethral biopsy at the 5 and 7 o'clock position near the paracollicular region of prostate.
So we've talked about TURBT. What next? What is the role of who is next? I mean, some people are keeping quiet. Ritesh.
Yes, sir.
TURBT is complete.
Yes, sir.
Patient is ready for discharge. Okay.
Yes, sir.
What is your opinion about a re-TURBT?
Sir, depending on the histopathology report, if it comes as a high grade or not, respectively, we should go for reassessment, cystoscopy after 3 weeks.
Why?
Sir, in around 33% of the cases, there is upstaging of the tumor or recurrence of the tumor is also seen. So for that reason, we should do a reassessment, and depending on the finding, we should do re-TURBT if the tumor is present.
So what are the specific indication of the restage TURBT?
Specific indications is that our histopathology report is a history of high-grade tumor.
Okay.
Or if there is no deep muscle present in the histopathology report,
okay.
No deep muscle seen.
Yes.
Another is that
Be specific. This is very important question. When you will do restaging TURBT?
yes, sir.
There are 3 situations.
Complete resection.
Yes.
So if there is suspicion
there
of incomplete resection in my first surgery, number 2, if it is a T1 tumor, number 3, if it is a high-grade tumor, and number 4, if there is muscle not present in the
muscle not present. Okay.
Yes.
Very
good. Very good.
Clear-cut indication.
So one question.
Excellent.
This patient has a 2 centimeter papillary lesion. You have done a good TURBT. Will you want to do anything intraoperatively or perioperatively before discharge the patient?
Yes, sir. If facilities are available, I would like to give intravesical chemotherapy, single installation of intravesical.
Why?
Sir,
Why?
So, because this tumor is a single, apparently, sir, low to intermediate grade tumor, and I have done a complete resection without any perforation. There is no active hematuria. So, in this situation, if I give a single sitting of intravesical chemotherapy, it will reduce the chances of tumor recurrence to at least 14%.
How? What is the mechanism of action mitomycin C which given intraoperative?
So the mechanism is that mitomycin C actually kills the circulating tumor cells and prevents its reimplantation
Yes,
within
the
the resected area.
reimplantation. The specific term is reimplantation.
Other than mitomycin C?
Sir, saline irrigation, which we use regularly, is an option. Sir.
No, other than mitomycin D, you have to tell about what is the idea? Had it been a high-grade tumor, suppose it was a high-grade tumor, G3PTA, although quite rare, G3PTA or PT1, you will do a re-TURBT after 3 to 6 weeks, or whatever is the your preference sort of. But will you give an immediate post-operative chemotherapeutic installation in a patient who is having a high-grade tumor?
No, sir. In high-grade tumor, single intravesical installation of chemotherapy is not.
Why?
It is only in low and intermediate grade. Because in high-grade tumor, it won't change the prognosis of the patient, or it will not reduce recurrence or progression of the disease.
See, none of the chemotherapy till date has been proven to prevent progression. Mind it. It's only BCG that is
yes,
to prevent progression. All the chemotherapy agent which we use pre-operatively, post-operatively, or immediate or delayed, is meant only to prevent recurrences.
Right.
Vikram, tell us something about your opinion about the advanced cystoscopies. you may or may not have practiced?
Sir, there are certain advanced cystoscopy technique.
Commonest, the commonest two, give one-liners on it. Atanu, can you deal with this?
Vikram, tell.
Yes, sir. Narrowband imaging is one option. There is another option of blue light cystoscopy. There is optical coherence tomography and confocal laser endoscopy.
Only two I have asked for. Listen to the examiner. Don't forget to listen to the examiner. He asked for two, you're giving 5.
Which you have done.
The commonest is PDD and narrowband. Hello?
So PDD is the commonest.
Yeah, correct. So what? Tell us a little bit about it.
So in PDD, we use certain intravesical agents like 5-alpha-livolinic acid or hexaamino-livolonate, which when given intravesically, they're taken up by the tumor cells. Then while using cystoscopy, when you use a blue light, they give out a red fluorescence, which will help us in better assessment of the tumor margin and whether if any suspicious lesions that is not visible in normal cystoscopy, white light cystoscopy can be visualized.
So which system would you use in your OT?
So we use a white light cystoscopy.
White light cystoscopy, which system? It's a Storch system or Olympus or Striker?
So we have both Storch and Olympus.
So Olympus has a feature. What is it?
So I'm not sure.
Tell them quickly.
What is narrowband imaging?
So narrowband imaging uses two different wavelengths of light, which evaluates the superficial and the deeper layer and also the vascularity of the lesions.
So what does indicate it? When you do a narrowband imaging, what will you see?
See, it will help us to differentiate, see as the extent of the tumor extension, whether it is extending to the superficial layers or the deeper surfaces.
No. Whether the normal looking
vascular tumor and normal surfaces.
Okay. So in the Olympus system, there has a system that you change to the NBI and see whether there is any suspicious lesion is there or not. Okay. So we most commonly use narrowband imaging and blue light cystoscopy. Otherwise not commonly used.
We're coming to pathology now. Now the patient comes back to your follow-up. You agree with this classification?
Yes.
Yeah?
Yes.
Which is the most? Goes without saying, isn't it? It's TCC. Yeah?
Yes. It is.
Amongst the TCC, what is the most commonest? Let's not get into the variants now. We will never finish. We've done this. Recommendation for performance of RETUR, incomplete initial resection, high risk, HGPTA, high-grade tumors, any T1, resection to include the detrusor muscle not sampled, and presence of LVI. We've forgotten that.
Yes.
Prognostic factors now. Prognostic factors for recurrence and progression. I'll remove this. Vikram, tell us the prognostic factors.
Yes, sir. For prognostication, we use the 2016 URTC system, which includes the 6 factors, such as the number of the tumors, the size of the tumors, whether there is history of any recurrence, the T stage, the grade of the tumor, and presence or absence of carcinoma.
Which is the most single important prognostic factor for a bladder cancer?
So much time. You should not be taking so much time.
T stage.
Grade. We said T stage it's a?
Yes, T stage.
No, it's a grade only.
It's a grade.
Grade only. It will be
to understand any bladder cancer is 2 different diseases. It is a low grade disease and a high grade. Should never utter T stage.
You're aware of this? Pathological risk stratification
Yes.
has changed. Vikram, you agree with this?
So,
Are you aware of this?
Yes, yes, I have read about this.
Well, what do you practice now?
Sir, so we prefer the 1973 WHO classification system.
Actually, doesn't matter.
Actually,
No.
nowadays you will never find a report telling grade 2 PTA sort of thing. It is either grade 1 or grade 3 sort of thing. And everybody has shifted from there to any low grade or high grade system.
So if a patient presented to you with a histopathology report of papillary urothelial neoplasm of low malignant potential, how will follow up this patient?
So in this patient, I will look at the OT report what the intraoperative finding was.
Suppose
And whether
this patient has a 2 centimeter tumor, you have done a TURBT, now report come to be a compound, PUNL. So what will be your follow-up protocol?
So in this patient, just I will look at one thing, whether the resection was complete or not. If the resection was complete, then sir, I will just follow up the patient with a cystoscopy and cystoscopy and urine cytology at 3 months and at end of 9 months. That is 3 months and 1 year.
Basically, we only do the cystoscopy. Urine cytology is not done in case of the PUNLMP. Initial days, it's thought that it may not require a follow-up, but nowadays they are saying that the low grade and the papillary urothelial neoplasm of low malignant potential is very narrow margin of differentiation. So it should be treated as a low grade tumor nowadays.
In the risk stratification, any other modernization has happened, Vikram?
So the last EAU 2021 guidelines has proposed a new risk stratification system.
What is it? Yeah, exactly. What is it?
So it has updated the system after the Quito protocol was proposed, and it has also taken into consideration.
What is Quito proposal?
So Quito proposal was done to assess the short-term and long-term risk of progression, recurrence and progression in bladder
In
tumor
BCG
patients.
cases, isn't it?
In post-BCG cases, which was not.
Let's keep that out of the system now. It is very confusing, you know. In AUA risk stratification, UA risk stratification, now you bring in Quito, you're going to get completely and thoroughly confused. And for the exam purposes, it's better to stick to one. Let's stick to EUA, because I'm asking you about the UA risk. That is changed. What has changed?
So EUA, apart from the regular factors which we have discussed, they have also included 3 preclinical factors like age of the patient more than 70, multiple tumors, or size more than 3 centimeters in classifying the patients into different risk categories.
Now, this slide is important. This is what, in today's day and age, if you really want to show off, you must be up to date with this. Okay? The age, size, and T1 lesion on one side, the grade on one side, and CIS on the other. These are the 3 factors that we must be completely conversant with in order to now risk stratify it into low risk, intermediate risk, high risk, and a very, very high risk group.
Yes.
Now, boys, please be careful. This is the newest addition that you all need to be conversant about. Gone are those days when you will say, fine, we know that is a low grade or a high grade. Life was very simple 5 years ago. There was a T stage and a low grade and a high grade. Today, it has become far more complex. And we have to factor in CIS or not, high grade or low grade, and this factor of size, depth, and the patient's age. Okay? We'll give you a little time to comprehend this. I'm sure everybody knows this. We will now get into, while you're looking at this, into management. We've done the TURBT. Atanu has asked you about, how you will decide on what. Tell me, any role for, who's going to answer this? Let me ask Kamal. He's quiet for some time. Have you gone to sleep, Kamal?
No, sir.
No, okay, you're awake. Anytime you've done or imagine doing a radical cystectomy in NMIBC?
Yes, sir. Radical cystectomy will do.
You do?
Yeah, no, I've assisted.
Although no, deal with him. I can't deal with him. He's too clever.
Basically, sir, asking about what is the indication of radical cystectomy in a case of NIUBC, non-muscle invasive bladder cancer.
In non-muscle invasive bladder cancer, if patient is BCG failure patient, sir, and with variant histology if there, sir, in the final reports. So any very high risk tumors are as per the UA risk guidelines, then we can go for early cystectomy in those cases, sir.
Okay, so what is the very high risk?
So very high risk groups are T1 high grade tumor with without CSS if all the 3 additional risk factors are being there, like the age is more than 70 years, size more than 3 centimeter, multiple tumors, or T1 high grade tumor with CIS, TA high grade tumor with additional 2 risk factor with CIS, sir.
So that is the one important thing. Initially, previously for a TA lesion, we was not opt for any radical cystectomy.
Yes,
but
sir.
nowadays, TA high grade with 3 risk factor, we
Yes,
can
sir.
give the option of radical cystectomy.
Radical
That is the one important changes have. Okay.
Who will decide
Yes,
BCG
sir.
failure?
Sir?
How will decide whether the patient has a BCG failure?
Yes, sir. Yes, sir. But if the patient develop a high grade tumor during the 3 months of induction course, or TA high grade tumor or at 3 months or at 6 months, and development of CIS at 3 months and persistently 6 months with induction course or the first course of the maintenance dose, sir.
It's an Indosec full course of induction
plus yes, sir. First course of maintenance.
Maintenance schedule. If even after that you're finding an CIS or high grade cancer, that means is a BCG failure, and the patient is fit enough, he should be offered for radical treatment.
Radical system.
कौन बगे और दायरे डेटल
So Kamal.
Yes, sir.
Just tell me the indication of BCG therapy.
Sir, in a patient of high grade tumor, we'll do the BCG. In a patient of CIS, we'll go for BCG. In case of T1 tumor, we'll go for some BCG treatment.
Okay. So whether BCG will, why the BCG used?
So BCG is preventing the recurrence as well as progression, sir. Progression of the disease. That's why BCG is being used, sir.
Okay. So what is the dosage of BCG?
No, we'll come to BCG a little later on. We've got a separate presentation for that. So I think we are happy with NMIBC, but have you ever, now let's give you a googly. In TA tumor.
Yes. Yes, sir.
Anytime you can recommend, you're licensed to recommend an RC?
Not every time, sir.
Not every time, of course not every time. Come on.
Yes, sir.
You failed the exam. I'm telling you, is there any case where you can have the license to do a radical cystectomy?
Sir, if TA tumor is very extensively fully involved, the bladder,
exactly. So just reminding yourself, nothing to be afraid of. I once did it only one time. This was in England. First chance, we went to do in a TURBT, and the whole of the bladder was like Sundarbans. You could not have done any resection whatsoever. Fortunately, the guy was a dentist. We came out of the theater in Oxford and explained to his wife, and then and there we did a radical cystectomy. It was very simple. He got cured, but a bold decision, but it can be done. Where it is extremely expensive, you cannot maneuver your resectoscope. So please remember this. NMIBC does not equate to 100% of the times to the stepwise management that we do. Next, we now pass on to our next quickly. We've done an hour of NMIBC. We will now ask Shomen to take the lead and others to help as well, please. Very important subject. We must finish in another hour. Lots of things to discuss. Number 2. Oi. MIBC. Yeah. Okay, Showman.
Huh. Start with the image.
It's Otono's case. Otono, you can describe this with us. Hello, Otono? Where is Otono? Otono, are you there? Otono is gone. Who's going to face this? Ritesh? Ritesh, are you here?
Yes, sir.
Ritesh and probably sir, Dr. Sandeep Manna.
Sandeep, yes, yeah. He's gotten to the tail. Yes, Sandeep. Yeah. Carry on, Showman.
Yeah, we will start with this image.
Yeah, describe this. Start. MIBC. Is this an MIBC?
Who is facing this?
So, Dr. Ritesh.
Ritesh.
Yes, sir.
So, what you see in this picture?
Yes, sir. This is a transverse view of a CT scan showing at the level of hip, we can see the bladder. Inside the bladder, we can see that there is an irregular shadow, most probably a space occupying lesion.
Now, just I tell you, sort of history. Patient has a history of recurrent hematuria, gross hematuria. We investigated. Already you have seen what the investigations are done, ultrasonography done, and finally CT scan is done. This is the CT scan picture. Okay, contrast enhanced CT scan of the, here you see the pelvic region. You see the pelvis, a bladder, the other structures around the bladder, and extravesical structures. So what you look for, what are the things you will look in cases of CT scan pelvis, in suspected case of bladder tumor?
Yes, sir. So this is an excretory phase urography film. We can see that there is a space occupying lesion. It is single, sessile, large, and it is involving the left lateral side of the bladder, left lateral wall of the bladder, and also we can see that it is going beyond the bladder wall on the outside.
There seems to be extravesical extension.
The lesion. Yeah?
There seems to be extravesical extension.
Extravesical extension can be seen, but so I'll need enhanced films to describe the lesion.
Okay. What are other things you will look for?
So I will look for if there is a extravesical extension or if there are lymph nodes present or not.
Where you look for lymph node?
Sir?
Where you look for these lymph nodes?
Sir, like I'll see for like along the hypogastric vessels, common iliac, internal, external iliac.
And what is the exact location? Is there any landmark where you look for pelvic lymphadenopathy from the CT scan?
Yes, sir. At the level of acetabulum.
At the level of acetabulum, on the over obturator internus muscle.
Yes, sir. Yes.
Okay, over the obturator internus muscle. Can you see any enlarged lymph node there?
No, not in this film. There is a small.
There are some, yes,
there are small
suspicious lesions are there.
Suspicious lesion just behind the tumor mass, but I am not very sure I can call a lymph node in this film.
Okay. So, what is your impression from this film?
So my first impression is that this is a muscle invasive bladder tumor with query lymph nodes positive.
Would you say it's a muscle invasive or the extravesical extension?
Extravesical extension is present.
Muscle invasive, not whether there is extravesical extension. What tells you that there is extravesical extension?
Sir, this tumor mass is going beyond the contour of the bladder, and also the
extravesical. What is the term actually used?
Macroscopic extension.
No.
What is the layer of the bladder?
Serosa, extraserosa.
Extraserosa, and anything more? What? During TURBT, we sometimes say the muscle is not there. We are seeing the fat.
Fat can be
so. So what is the fat standing?
Actual term is
fat standing, sir.
extravesical fat standing. Okay, that gives clue that that might be extravesical extension. There might be.
Okay, there might be.
Okay.
So what is
So,
the
but
reason?
in this case, we can see that there is extension. If
Yeah.
there is fat standing, the black gap between the tissues it's lost. But in this case, we can clearly see it is going beyond the contour of the bladder, and also that side the bladder is not distensible. On the opposite side, it is distensible, but on the ipsilateral side is less distensible. So the loss of distensibility, and also there is extravesical obvious extravesical extension.
So what other investigations you want to do? Now let us proceed.
Yes, sir.
Because we have already discussed about CT scan, MRI. Okay, already discussed in last case. So nothing we will gain after discussing same thing.
How will you manage this case?
Yeah, how will proceed?
Okay, so this is we have a CT scan for this patient. So imaging wise, we are complete. We know the extent of the tumor, and so is it the same case we did TURBT for, or is the new case?
No, it's the new case. It is the same,
It's a new
not the
case.
same
Okay,
case.
sir. Okay, sir. We would like to have a histopathological diagnosis. For that, we will do a biopsy of this patient.
Whether you go for TUR biopsy or TURBT?
TURBT, we will not be able to completely resect, sir. We can take a biopsy of this patient, and we will invariably need to do further treatment, because in doing TURBT completely, we will be already outside the bladder if we are dissecting the tumor.
So your aim will be to do complete TURBT as far as practical. Okay.
Yes, sir.
Not beyond your capacity. If you see
Ritesh, erase the haziness in your mind. The answer to this is a straightforward answer. It is a TURBT. Okay.
Okay.
If you haven't learned it so far, please learn it. Your exam is around the corner.
Yes, sir.
And align all your reasoning to TURBT. Forget about biopsy. Okay. So this is a clear case where you will do a TURBT.
Yes.
Okay.
Okay.
And then?
Do you have the report, biopsy report? Yep, done. TURBT is done. Do you have the biopsy report?
Biopsy report is a muscle invasive, high grade.
Okay.
There is lymphovascular invasion.
Okay.
Okay. So it is T2. T2, say it is N0. Okay, it is not confirmed whether the lymph node is informed. Can we see the biopsy report, radiologist report we have?
No, we don't.
No, sir.
So there is no significant lymphadenopathy, and the report is T2. So T2, N0, M0.
Yes, sir.
Okay. How will you proceed now?
Okay.
So what will be your next step?
Okay. Next, sir, I would like the patient. I will give the option to the patient that he needs to undergo chemotherapy prior to radical cystectomy in this case, because there is extravesical extension of this tumor. So that will help in doing radical cystectomy later on.
So you advise neoadjuvant chemotherapy, isn't it?
Yes.
Okay. So what drugs are used in neoadjuvant chemotherapy? And why, first tell me why neoadjuvant chemotherapy, why not straightforward radical cystectomy? Because the standard of care in cases of muscle invasive MIBC is radical cystectomy. So why neoadjuvant therapy? You are taking time, you are wasting time.
No, sir, we are not wasting time. By giving neoadjuvant chemotherapy, we'll be reducing the tumor load of the patient. We will also be, if there are any local lymph nodes positivity, and that will also be reduced. Prognosis.
What is the
Just
concept?
tell me 1, 2, 3, 4, 5. Just 1, 2, 3, 4, 5. What are the advantage of neoadjuvant chemotherapy?
Sorry, it deals with the macrometastasis. It helps
Number
in creating
one, okay. Yes.
Negative margin during resection.
Any survival benefit is there?
And yes, there is a survival benefit.
How much?
It is about 10% in 5 years.
10%. Where it is written 10%? 10%, you're sure? It is about 5 to 8%. Initially, it was
5% at 5 years. Yeah.
Now it is 5 to 8% at 5 years.
5 years.
Okay, not 10%. Exactly. So there is a overall survival benefit of 5 to 8%. Next, it deals with the micrometastasis. Next.
No, let's ask another opinion about this. Manna, are you here?
Yes.
What would you do? You're faced with this 65-year-old or a 70-year-old patient who has got no other comorbidities and he has got this tumor. You have done a TURBT, you've got a high-grade T2 lesion on biopsy, but this is the picture. What would you advise? Ritesh has said he'll go for neoadjuvant chemotherapy followed by the obvious. What, in your opinion, what would you do? If it had come to you, what would you have done?
So being a surgeon, sir, I would look at whether inspect the CT plate and whether the mass tumor is resectable completely. If it is resectable completely, I will go for radical cystectomy first, and then afterwards, if necessary, I can get adjuvant chemo.
I think this is a very safe answer. This is not a very scientific opinion that I'm giving you, but
what is
to all the boys,
what is in the guideline?
The guideline says that
neoadjuvant is better. First, you have to tell the guideline. What is written in the guideline?
Dr. Somen,
yes,
thing that they are telling biopsy report to be high grade T2. Had it been T3, you are forced upon to do and give a neoadjuvant therapy.
Who's speaking?
I'm Dr. Narayan sir.
Oh yeah, okay, sorry.
I'm telling, if it is T2, you can still go ahead and do a primary radical cystectomy. But if it is T3, you will be safe to give neoadjuvant chemotherapy followed by surgery sort of thing. That's what you should answer me. You can jolly well tell that I'm a surgeon, I will go ahead and do a surgery if it is resectable. But if it is,
I think they should examine it in this way. What is written in the EOA guideline or other guidelines, okay, and what we practice in your center. Maybe the same thing, this chemoradiation or radiotherapy is not available in your center. So you straightforward go for radical cystectomy, and if needed, we'll go adjuvant.
Yeah, I think Somen is very right. I think the student can answer that, the guidelines says that this is what needs to be done. But in our center, we practice this because of lack of facilities. I think then you are safe in the exam. I think everybody agrees to this. The guideline statement can come first, because my inclination is to get this patient into radical cystectomy.
Also,
however,
the guideline says this, but only you see in the literature, only 12% cases they have done neoadjuvant perioperative adjuvant therapy. Usually, most of the cases, the straightforward go for radical cystectomy. Okay.
So I think the way to comprehensive answer should be, guideline statement says this, but in my institution, I practice this. And the justification of that is what Somen said just now. I mean, the survival advantage is only 5 to 8%. We want, because of economic reasons, etc., be very smart. You want to beat the system. And you want to get into radical cystectomy. You don't want to get into the mess of, how much dose and whatnot, which drugs you will choose for neoadjuvant. We'll come to neoadjuvants later. So you will do a radical cystectomy in this case after you face the examiner tactfully with guidelines.
So according to you, what is radical cystectomy? How will define radical cystectomy? What are in other words, what are the structures you are going to remove in a male patient?
So the complete urinary bladder with prostate and seminal vesicle, along with the lymph nodes.
What lymph nodes?
So
what are the lymph nodes you are going to remove?
Pelvic group of
lymph node. Somen, we'll come to that later. We've got a long discussion on that. But what are, first of all, the indications of radical cystectomy in general? Can you tell me that? You have said you will do radical cystectomy. In general, what's your attitude for a radical cystectomy? In which cases are eligible?
Muscle invasive bladder cancers and Then again, non-muscle invasive bladder cancer for early
No, no, muscle invasive mein bolo na, ar ki ache? What else? What, I mean, redefine this. Reclassify. What are the category of patients that you will do?
Sir, muscle,
Stage-wise, first answer is stage-wise, no?
okay.
T2, T3 you will do.
Yeah.
Then what?
T2.
Anything else?
Provided there is.
You agree with
no
this?
nodal-
Come on, let's cut short the time because we are over now the time. Indications are patients with T2 to 4A, N0, M0, high risk or very high risk, and recurrent MIBC. BCG refractive, an extensive papillary disease. Okay? You have to be comprehensive exactly what the indications are and which category does this fall into. This falls into category 1 for the moment.
Yes.
Also category 2 because it's high risk. So in your mind, you have to be clear what category are you classifying this particular patient into. Yeah? Okay. Now, the other thing to remember is if the patient wants to delay the surgery, how long can you delay it for safely?
Maximum 3 months.
Yeah.
Not more.
So that's a documented thing. Pelvic lymphadenopathy. Let's now come. Soman wants to get into this, which is very right. Is pelvic lymphadenopathy at all necessary?
Yes, sir. It is necessary for prognostication as well as therapeutic value.
What are the lymph nodes actually involved in case of bladder cancer?
Sir, the hypogastric nodes, external iliac, obturator, and presacral nodes.
Initially, that in the two pelvis, these are the lymph nodes they are involved. This is the level 1 lymph nodes. There are certain terms are used like limited, extended, and supra extended also. Or
Yes,
there may be
standard
level
extended.
1, level 2, or level 3.
Yes,
Okay,
sir.
so
Then
what is level 1 and what is level 2 and
so
what
this
is
one,
level 3?
this one is level 1. Level 2 will be common iliac group of lymph nodes, and level 3 will be para-aortic and pre-aortic and paracable.
Level 3 is?
Pre-aortic and paracable.
You are sure? Level 3 is pre-aortic paracable?
Yes, sir.
No. Level 3 is up to the inferior mesenteric artery. Up to
Yes,
inferior mesenteric artery. Okay. Level 1 is up to bifurcation of the common iliac. Common iliac with pretracheal, pre-sacral, and up to level inferior mesenteric is level 3. Okay, so why these different types of what is the advantage of doing limited or extended, and what will you prefer? What is the evidence?
So the evidence is if there are one study showed that if there is more than 25 lymph nodes and there is extracted, then there is better survival chance in 75% of the case.
We will come to number of lymph nodes will come to later. I mean level. Why level 1 is why level 2 is better than the level 1? Is there any evidence that it increases the overall survival or recurrence, prevent the recurrence?
Sir,
is there any evidence?
Yes, sir. It prevents the recurrence in the way that if there is extended lymph dissection is done and the lymph nodes are found to be negative, then there is a better prognosis. But if it becomes positive, that there is chances of local recurrence, nodal recurrence.
Very confusing statement.
There is important study but done by the Cleveland group. They have shown that the 5-year recurrence-free survival in cases of node positive disease. Okay, when there is limited resection is done, it is only 7%. 5 years overall survival, recurrence-free survival is 7%. Whether when they have done extended lymphadenectomy, it is about 35%. So there is definite survival benefit is there, overall survival benefit. Okay, that's why extended benefit is preferred up to common iliac lymph nodes. Okay, now comes you are talking about the number of lymph nodes. So is there any cutoff point of how many lymph nodes you have to remove? But I mean, what indicates adequate lymphadenectomy?
Sir, more than 12 is considered to be adequate lymphadenectomy.
More than 12.
Yes.
Is it? It is because there is no consensus about this, how many lymph nodes you will remove. There are different studies. Some say 16 lymph nodes, some say 25 lymph nodes, some say 45. Okay, on an average, 15 to 16 lymph nodes, quite enough.
15 is the cutoff point.
Okay,
Yeah?
that is the cutoff point.
So what is the important, whether it is a number of the lymph node or it is a number of the positive lymph node?
We'll come to that. Yeah.
Or in other words, it is the density.
Density.
There is another term called density of the lymph nodes, and another thing is coming, the extranodal extension. These are some important prognostic factors are there. You know, what is the lymph node here? I mean, per year, positive lymph node percentage density.
Density. It is lymph node density, that is number of lymph node positive divided by total number of lymph nodes extracted.
So, what is the cutoff point? Below which it is better, above which it is not so good.
So it was I have forgotten.
It is 20%. Okay.
So this is another classification that we all use. This is limited, or the commonest mode is standard. You agree with Manna?
Yes, sir.
Yeah, you agree with this classification? In the standard lymph node, what is the idea of the standard lymph node?
Sir, the pelvic complete pelvic group of lymph node, that is
internal iliacs, internals, external and obturator, isn't it?
Yes.
Yeah. Extended is proximal boundary crossing of ureter, common iliac artery, rest landmarks are standard as the template. Now, this debate is going on, and this is a good optimum article I found, extended versus non-extended lymph nodes. The lymph node yield in EPLND and non-EPLND, of course, it is favoring EPLND. Okay. Meta-analysis of positive nodes. Again, positive nodes are more in favor of EPLND. Meta-analysis of recurrence-free survival. Recurrence-free survival is proved to be better in extended PLND. Interesting now, meta-analysis of RFS in patients with negative lymph nodes. Follow this, very important one. Negative lymph nodes is better with EPLND. Positive lymph nodes also better, obviously better. Patients with RFS disease in 3 and PT3 and PT4, EPLND is better. But patients in PT2, non-EPLND is favored. It's very confusing. You have to deal with this carefully. Your answer in the exam should be, I think, standard lymph node template is what I practice. There is evidence this way and that. Interesting evidence is RFS is good in extended lymph node dissection, positive or negative. Okay. Now, is that clear? Kamal, you seem confused. What should be your answer if you are asked in a PT2 and a PT3? Obvious PT3.
So
what is the extent of lymph nodes and why?
Sir, just now we have seen, sir, if it is more than PT2, it is PT3, then it will be extended pelvic lymph node dissection, sir.
The problem is, the more you go for yield and the more extension you go into, like level 3 or super extended, whichever you call it, the advantage that you get out of removing more lymph nodes or extensive lymph nodes is offset by the time of surgery and the complications of surgery.
Yes.
And that is documented in literature. So for you guys, to play it safe, you want to get out of the exam unscathed, it is safe to play it, optimize it to standard lymph node. Tell them this takes me less time, gives me optimum result. And that is why I practice this. And I plan to do this as per our institution.
Yes.
However, you must know what the nuances are of doing extended and super extended. Or in other words, level 3. So many agree with this?
Yeah.
When do you do a urethrectomy? Somen or Ratanu, please carry on with this.
So what
We
are
have
the
to finish.
indications for urethrectomy?
If the prostatic urethra, there is growth in prostatic urethra, the prostatic urethral biopsy is positive, is a bladder neck involvement, or in female, if there is vaginal involvement and urethral involvement, then we have to go for urethrectomy.
And obviously, if there is a cut margin positive, isn't it?
Yes.
So a patient presented to you who have a prostatic biopsy previously. One patient presented with the prostatic stromal involvement. One patient presented with prostatic epithelial involvement. So to whom you will do a urethrectomy, to whom you did not?
Sir, urethrectomy would be done in case of prostatic stromal involvement because that is graver prognosis. For prostatic urethral involvement, then we can follow up the patient and
what counseling do you do if you follow up this patient?
That there are chances that it can go into prostatic stroma, then we have to do totally urethrectomy. And, there are chances of recurrence also, so there is a regular follow-up.
So two things. One is the positive surgical margin, urethral margin. You have to do urethrectomy mask. Prostatic urethral involvement you have to do. But if the only epithelial involvement, then you can give an option that urethrectomy may not be done, but there is a chance of higher recurrence from those who have not involvement. Okay, if you regular followed up this patient, then we can go for preserving the urethra, and also the neobladder can be done in these cases.
And how will you follow up this patient, this group of patient where this urethra is spared?
Sir, we have to do urethroskopy 6 monthly, then 1 yearly.
And cytology.
And cytology.
Very good. I think we'll stop the MIPC here and we will pass on to 2 more subjects.
Another subject was there regarding MIPC. What about the bladder preservation protocol?
We're coming. That's a separate subject, separate session. So we'll have to finish BCG immunotherapy in short, and then we pass on to the bladder preservation, with which we can go for lunch, I think. So when you're going to treat us? That's it. Atanu, will you take this?
Yeah.
Why BCG immunotherapy?
Kamal.
Sir.
That was the question previously. Why?
Sir, it prevents both the recurrence as well as the progression of the disease, the BCG immunotherapy.
Whether in both cases it's a low grade and high grade?
No, sir, it is especially for a high grade tumor, sir.
Okay. For a low grade, what will be your option? Suppose a low grade recurrent tumor, multiple tumor came to you. What will you prefer?
Sir, low grade, I will say it comes in the intermediate risk category. In that case, I will go for BCG, sir.
Okay. What about mitomycin in intermediate risk group?
Mitomycin, sir, prevent only the recurrence, not the progression, sir. Okay. So it is helpful in low risk in the primary category, sir.
So low grade disease can progress to the low grade TA-T1 can progress to the high grade or T1.
Low grade by itself doesn't get converted to the high grade.
Yes, that's the important. So in case of low grade TA-T1, the mitomycin can be given because the toxicity of BCG is too high than mitomycin.
Yes.
Dr. Esen Mondol bolchi.
So for the high risk group,
আমি আর
the
কালকে
recurrence and
পারিনি
progression for both.
Showman, mute, please. Showman, mute, please. Showman, please mute yourself. Anyway, carry on.
মনে হয়নি apparently.
So what will be your preparation for the BCG for this group of patients?
Sir, first, before we have to find out the history when the TURBT is being done, what is the time elapsed period.
Okay.
And then after this, we have. Hello.
Yeah, well, continue.
Oh, yes, sir. Then we have to do an urine analysis to rule out any hematuria, and we have to see whether the patient is on any immunosuppression or not. And we have to then take out a history of the patient, a history of BCG sepsis or any past history of tuberculosis.
Okay, thank you. আমি পরে আবার ফোন করে ফোন দেব।
If yes.
What will be your timing? What will be your timing for BCG therapy?
It is 2 to 4 weeks, sir. Here we give 4 weeks.
4 weeks.
4 weeks.
So what is the absolute contraindication, Dipankar?
Now we're coming to contraindications. Yeah. Okay. We want to do. Okay, carry on.
Yes, sir.
Dipankar, what is your absolute contraindication?
Dipankar is not here, I think. Is he?
Yeah, I am here, sir.
Dipankar, Vera is there.
Yes, sir, I am here.
Okay.
Any immunosuppression, sir, absolute contraindication. If the patient is immunosuppressed, that is absolute contraindication for BCG.
Okay, anything more?
So any history of gross hematuria?
Okay, that's the most important thing. A patient presented with gross hematuria, you should not give him BCG therapy.
Yes, sir.
So, which strain? Which strain we commonly use for the BCG? Kamal?
Sir, Dennis 1331 strain we commonly use in India, sir.
What is the doses?
Sir, doses standard dose we use as 120 milligram in 50 ml NS we are giving, sir. We are following the SWOG protocol here. We divide in the induction phase and maintenance phase. In induction phase, we're giving weekly basis for 6 weeks. Then in the maintenance phase, 3 weekly at 3 months. Then at 6 months. Then at 6 month interval to 3 years, sir.
Okay. So for the all of the patient, will you continue for the 3 years?
No, sir. In high risk, in EAA guidelines, as per EAA guidelines, the high risk categories we use for 3 years. Intermediate, we can stop it up to 1 year also.
Okay. For a patient with a less than 2 centimeter tumor, patient at a high grade, will you continue it for 3 years?
Less than 2 centimeters, sir, patient age, and these are if in the favorable risk groups, then it falls into the intermediate risk group, then we'll continue for 1 year only.
No. It's a T1 high grade T1 less than 2 centimeter.
T1 high grade tumor less than 2 centimeter.
So what the recent literature say, whether we continue for a 3 years or a 1 year?
That I don't know, sir. Like the latest, I don't know, sir.
So for the high risk group, for the smaller tumor, if we continue up to 1 year, then we can follow up this patient also.
Okay.
What is adequate BCG therapy? You've said six installations. What do you think? You can't tolerate. We're now getting into BCG failures, huh? You learned the indications, contraindications, when to give and when not to give.
Yes.
Now you've started giving.
Yes, sir.
And the patient is having failures. Now, which one would you consider as adequate?
So for BCG failure, we have to complete the induction and reinduction or induction plus first course of maintenance, sir. As per the definition.
What is the when the BCG effect appears? How many doses? After how many doses?
Look, read this. Adequate BCG, adequate, minimum. Patient receiving at least 5 of the 6 planned installations of induction treatment and at least 2 of the 3 planned installations of maintenance treatment over a period of 6 months. Now, make it clear.
Yes.
Wanted to say something, Shauman?
Yeah. No, okay.
Yeah. Now, that's adequate. And these terminologies you must get used to. What is refractory? Kamal,
Sir, if the participant,
either you know or you read, do something.
No, sir. As per UA, three things are there. If T1 high-grade disease even at the 3 months after treatment, if high-grade disease, TA high-grade disease at 3 months and persisting up to 6 months, if CIS
Yeah.
also persisting from 3 months to 6 months. Then
Yes. So in one line, persistent high-grade disease at 6 months after induction and maintenance of treatment, or any progression in stage in 3 months.
Yes.
That summarizes what you were trying to say.
Yes.
Now you memorize this because, these are terminologies that you need to be completely familiar with.
Yes.
Suppose somebody comes and says, a patient comes and tells, forget about the exam. I just cannot take it anymore. So there your definition of, has he reached adequate?
Yes.
You have to define in your own mind, is he getting refractory? Because refractory is an indication for RC.
Yeah.
There are alternatives nowadays. Relapsing is another thing. These are the 3 concepts you need to get clear. Relapsing, early relapse at less than 12 months, intermediate relapse. Definition, recurrence of high-grade disease after a disease-free interval of 6 months, after adequate BCG induction and maintenance. That's relapsing. So there is adequate, there is refractory, there is relapsing. Yeah? You were talking about contraindications?
Say after BCG therapy, during your follow-up therapy, you find a low-grade recurrence. So how will you define it?
So it is not fall under any BCG failure because it's a low grade. It has to be the high grade to define these BCG failures.
So it has to be tackled other way. It is not a BCG failure. Okay.
You're clear about contraindications to BCG therapy? I've tried to summarize it.
Kamal.
Yes, sir.
A patient presented to you or who was on BCG therapy after the 6 doses, after 1 month with history of fever, cough, along with testicular swelling. On examination, if I find there is epididymal nodule, now what will you do?
So patients had a disease fall in the systemic organ involvement. So epidermal orchitis is there. So we have to. So fever duration is how much, sir?
So after 1 month, patient presented with fever along with nodule and a cough. Now what would you do?
Sir, I will advise for first. I will advise for sex X-ray. I will advise for liver function test. I will send a patient urine for culture and sensitivity. Then I will stop the BCG and start giving isoniazid and rifampicin. And I will see whether
patient has solid organ involvement. So
Yes.
which category it is?
It is last category.
Which category?
It's a very high risk, sir. Very severe, sir.
Grade 1, grade 2, grade 3. It is
Grade
written.
3, sir. It is grade 3, sir.
Grade
Okay.
3.
So
It's
in
a grade-
grade 3, what will be your advice?
Sir, we'll stop the BCG, we'll give isoniazid rifampicin, we'll start empirical antibiotics, and if not responding, we'll go for steroid treatment also.
So only isoniazid rifampicin?
No,
plus ethambutol and admit the patient.
Yes, sir.
Yes, ethambutol. Why not pyrogenamide?
Sir, it is resistant, sir, nowadays.
It doesn't work with the BCG spin which we are using.
Yes, yes.
So after that, the patient has received the ATD, whether you will again advise for BCG later on? This
No,
patient,
it becomes a contraindication to giving BCG, sir, anymore.
so patient does not want to go for radical cystectomy. So what will be your other option?
Other patient doesn't want to go for radical cystectomy, sir. Intravesical nowadays, some improvised intravesical chemotherapy has been come. We'll counsel about the intravesical chemotherapy, sir.
Okay. So which are they?
Sir, in this case, sir, we can advise for gemcitabine. We can advise for doxorubicin, valrubicins, and some newer modalities of mitomycin giving drugs also there to increase the efficacy, like electromotive then high wake, then microwave. So these things will give, sir. And immunotherapy also been come, sir, in our practice.
So which is the commonly used chemotherapy for this group of patients? It is only gemcitabine or a combination?
So it is combination in less toxic as this is gemcitabine and cisplatin, sir.
So patient received the 6-cycle BCG.
Yes, yes.
And what will be your follow-up protocol for this patient? How will you follow up this patient?
So for the high risk patients, sir, we'll do a three monthly interval check cystoscopy will do along with urine cytology and surveillance for 2 years, then 6 monthly for 2 years, then annually thereafter. And if
so, what will you advise to the patient when you patient came to you for a BCG therapy? Okay.
Yes, sir.
So how will you install BCG?
How will I? Installation of the BCG. So after all ruling out the contraindication, if patient is fit, so by
patient fit.
Yes,
patient is fit, came to you for the BCG.
Yes, sir. Then I will through atraumatic catheterization process. I will first mix the BCG with 50 ml of NS and in a syringe. Then I will install it by force of gravity, not giving in force, and ask the patient to retain the solution for 2 hours, and advise the patients to move side and side. And after that, patient will discard the urine, and when the
Side by side movement is necessary now?
Not sir, not sir. It is some
Just now said you wanted to do it.
And then after that, sir, patient.
This is not the answer to ortho. This is an answer for the exam.
Yes, sir.
Why are you saying that you will ask the patient to side by side?
Sir, to bath the whole of the bladder, sir.
Why? Is a bladder a fixed structure? If fixed volume structure?
No, sir.
So why? Next. So your patient asked, would you advise anything extra to patient? Patient then went home.
Yes, sir. Patient patient went. So before that, I will ask the patient to have not to have any caffeine or this kind of thing.
After BCG therapy, patient went home. Okay. Anything specific you will advise to the patient? It's a live attenuated vaccine.
Yes, sir.
So he should pass urine in a toilet, not in the environment surroundings.
Using bleaching agent. We have to
Yeah,
use bleaching agent.
They should disinfect the toilet.
Bleaching agent should be used for
Anyone.
You should disinfect the toilet after passing urine.
Okay, now let's summarize. Bikram.
Yes.
You take me through indications, basic. You are sitting in a clinic. I'm your new DNB. You tell me the role of BCG. I'll give you 2 minutes time. You summarize it. What are the indications? What are the fundamental contraindications? What is the dose? What would you define as? Tell me that quickly. Come on.
Sir, I would recommend intravesical BCG therapy to the patient if he belongs to the
Which patients?
intermediate and high risk categories. And sir, in a non-muscle invasive bladder carcinoma, I will recommend this, and I will tell that there's BCG helps in reducing the risk of recurrence and progression. Up to 30% risk of recurrence and progression it can prevent. And sir, I will also explain him the regimen that will use a first induction phase for weekly.
Yeah, okay. You've done the regimen. Yeah, fine. Induction and maintenance, you've done. Okay. Any contraindications in your mind that you?
Yes, there are some absolute contraindications, like whether he is having any active UTI, whether there is any history of traumatic catheterization.
Hematuria, huh?
Yes, a personal history of BCG sepsis, gross hematuria.
Yeah, fine, carry on.
Total incontinence, and whether there is any evidence of incontinence, and some immunosuppression, is now not recommended in as an absolute contraindication. I will recommend it within the relative contraindications.
then what would you classify as now it's working? First dose gone, second dose gone, third dose gone. Now he starts creating problems. You'll press on. Will you reduce the dose?
Sir, I will like to grade what are the symptoms he is having. In grade A and grade B, still I will continue with the management after treating the symptoms. But
Now,
in
suppose in grade 2, he is not willing anymore. Will you try a rate? In other words, does dose reduction play a huge role in efficacy?
Sir, no, sir.
How much dose do you give? How much dose do you give? Standard dose?
Say in our institute, we practice the 80 milligram.
Yeah. And when I was in England, we used to practice 120. And they were adamant about it. Even I do 40s. There is literature evidence that, dose does not matter. The desired dose is 80. Okay? Let us be clear that, desired dose is 80. In our population, even 40 doesn't matter. I forget this name. This Canadian guy has actually brought out a trial which says the dose does not matter.
Yes, sir, there is
Find it out. Yeah.
Sir,
Actually, you can reduce the dose up to 1/3 or 1/3 of the standard.
1/3,
dose.
yeah, correct.
Below, it will not be so much effective.
No. So after this, tell me what are the definitions of adequate, refractory, and relapsing? These are the 3 definitions you need.
Yes. So adequate BCG exposure would be if a patient has completed at least 5 of the 6 induction phases and 2 of the 3 maintenance phases blended out over a 6-month period.
What is refractory?
So refractory is the persistence of high-grade lesions while a patient is undergoing BCG. It could be a T1 high grade, a TI high grade, or a CIS.
Correct. Okay.
And
within what frame of time?
So within 6 months.
Within 6 months. Okay. Don't forget that. Now relapsing. So relapsing is after 6 months. Okay.
Yes, sir. Relapsing is one patient who has been completely treated and had a 6 months disease-free interval before high-grade disease.
So, boys, you understand the whole concept is 6 months. Okay. Adequate is the number game. Then comes the time game. Okay. Is that concept clear? When you say adequate, that's the number game. When you say it's relapsing or refractory, it's the time game. Within 6 months, it's not working, it's refractory. After 6 months of complete therapy, if it is there, that's a relapse. Now, suppose it is refractory. What's the option? What's the algorithm?
Sir, if it is a BCG refractory case, I will be inclined to convince the patient for a radical cystectomy.
Correct. Absolutely correct. This is the way to go ahead. Okay. This is why I'm giving a revision option from you. We are today practicing what we tell the examiner. He is absolutely correct. You must press on with radical cystectomy. Whereas there are many other options. Now the patient says, I'm not agreeable to it. Then what are the options?
Then the other options which my colleague has said, the intravesical installation of mitomycin C in this hypothermic installation or electromotive installation.
Thank you very much. I think this was an excellent session. This is a very, very, very important session. People pounce on you with BCG therapies. We're absolutely clear with the concepts of indications, contraindications, the dose, the adequacy, failure, relapse, and what are you going to gain the relapse? In conclusion, you have to aim for a radical cystectomy. Otonu, please now start your final session of bladder preservation. Otonu, have you gone for lunch?
Oh, I am here, sir.
Yeah, carry on. No, wait, bladder preservation is an important modern subject, and
we will face.
Yeah, who will face? Who has not faced so far? Dilip, you have not. You've been quite little quiet. You were there in the beginning.
Dilip and Ritesh.
Ritesh, yes.
Yes, sir.
First slide, do you agree with this? And then I'll hand it over to Atanu. Ritesh.
Yes, sir, I do agree with this.
You agree?
Yes.
Hmm?
Yes, sir.
Atanu, carry on.
Okay. So what are
Emphasizing
the-
on trimodal therapy, really.
What are the mode of bladder preservation?
Bladder preservation, sir, we can give complete chemotherapy plus radiotherapy to the patient, or we can do TURBT, re-TURBT to the patient, and followed by salvage adjuvant chemotherapy.
A patient came to you who have a 3 centimeter tumor located at the dome, came to be a muscle invasive.
Okay.
Okay. He is very adamant. He will not do a radical cystectomy at all for his morbid. So what option you?
Sir, we can give him the option of doing partial cystectomy if it is
Okay.
agreeable to that.
Okay. So what are the indication tumor characteristics of partial cystectomy?
Okay. For doing partial cystectomy, the tumor should be located at or near the dome. There should be no CIS changes. Tumor should be less than 3 centimeters, and
So whether you will go for a lymphadenectomy for this group of patients or not?
no, sir.
Why?
So because the pelvic lymph node involvement is more commonly seen in the posterior wall involvement when there is posterior lateral wall involvement. In the dome, if it is, we can go for urachal excision.
Are you're confusing me completely. Everything is appearing Greek to me. First teach me and then you face autonomy. And let's go back again.
Yes, sir.
What is the definition of what are the pillars of trimodal treatment? Now go back. You've confused everybody. Now restart. What does trimodal therapy entail?
The trimodality of the therapy
It's there. Come on, read it.
Okay. So it is safe and complete TURBT plus radiotherapy and concomitant chemotherapy.
So that's a new term, concomitant chemotherapy. Yeah. It's neither neo nor adjuvant or whatever. It's a concomitant chemotherapy. Okay. And the aim is to preserve the bladder. So that's trimodal therapy.
Yes.
So you will have to ensure maximal safe resection. You will have to give radiotherapy to the intact bladder. Controversy exists in lymph node radiotherapy and then concurrent chemotherapy. Now, Atanu, take over again. On these principles, let's proceed.
So what is the maximal TURBT or a radical TURBT?
The maximal tumor resection is that we should be able to resect the tumor as far as possible so that we can see the fat.
Is somebody hungry? Somebody hungry? Some big noises in there. Whoever is hungry, please mute themselves. Dipankar, maybe. Yeah, carry on.
So everyone is muted.
Okay. Ritesh?
Yes, sir.
Okay. So you have done a TURBT, it's a muscle invasive tumor. Now what we do next? Patient is not agreed to do a radical cystectomy.
Yes, sir.
What would be your option?
Okay, so we'll give radiotherapy to the patient around 60 to 64 gray, around 1.5 to 2 grays per day for 5 days a week. Concurrently, we'll give chemotherapy cisplatin based for 1 to 4 weeks and follow up the patient. And after the follow-up, after 4 to 6 weeks, sir, we will do restaging and cystoscopy of the patient.
Cystoscopy and restaging TURBT.
Yes, sir.
Okay.
And if there is no growth, then we will complete the course of chemotherapy. And if
How
there
many
is
cycle of
growth,
chemotherapy?
then we'll advise the patient to go for salvage radical cystectomy.
No. How many doses of chemotherapy? How many cycles?
So radiotherapy should be completed.
Cycle. What cycle of chemotherapy? How many cycle will you give?
So 4.
Okay. So 4 cycles to 6 cycles.
Yes, sir.
So what is your preferred chemotherapeutic agent?
Sir, we can give gemcitabine plus cisplatin, or we can give MVAC.
What are the large study with gemcitabine cisplatin or impact?
Gemcitabine cisplatin.
Okay, basically chemotherapy come to the urothelial carcinoma, all the study from the larger study from the impact study. Okay. Gemcitabine plus cisplatin is nowadays coming up.
Yes.
Okay. So what about the radiotherapy to the lymph node?
No, before that, Vikram, do you know, before you give clearance for chemotherapy, will you check anything for the status of the patient?
Yes, sir. The general condition of the patient.
Very important, yeah?
Yes,
We should not go back with the impression that we are actually doing it for unfit patients. Okay? So trimodal therapy is not for unfit patients because they might be unfit for chemotherapy for all you know. So what are those criteria?
So criteria is the general condition of the patient. We will score by the ECOG system.
Yeah.
So at 0 to 1 would be the best.
Exactly.
Patient.
So less than 2, yeah.
Also, sir, the renal function of the patient, the GFR,
Yeah.
is ideally should be more than 60 ml per minute, sir.
Yeah.
And, also, he should not have certain other contraindications like sensory neural deafness, type 2 sensory neural deafness, peripheral neuropathy, or type 3 NYHA classification heart failure.
Exactly. So it is extremely important to remember this, and then we can go on to this drug and that drug. Yeah. Okay. Carry on. Yeah. Carry on, Atanu.
So radiotherapy to the lymph node. Whether you will go the radiotherapy to the lymph node or not.
Yes, sir. Radiotherapy is to be given in 1.5 to 2 grade doses up to 64 grade.
Okay. So a patient who received radiotherapy came back to you after the 3 month or 4 month after a year. Okay. You have done a cystoscopy, TURBT, there was no recurrence. You already said that you were cured. Now patient came back to you after 2 years with the hematuria.
Okay.
So you have done a cystoscopy and you show the patient has the whole bladder is red. So what will be your diagnosis?
So in that case, we will be looking forward at a radiation-induced cystitis.
How will manage this?
So radiation-induced cystitis can be managed by giving intravesical alum to reduce the bleeding. We'll admit the patient, give blood transfusions, and give intravesical alum.
Okay. Straightforward intravesical alum. Have you done it? Intravesical alum?
Yes, sir. We have given in our institute alum.
How will you prepare the alum?
So we take sterile water and the sterilized bar of alum, and we mix in the ratio of 30 grams for 1 liter of water for each liter.
Okay.
And then give it over slow in irrigation of the bladder.
Okay. So you not responded to alum. Next.
If it has not responded to alum, if there is gross continuous hematuria, we can go for ligation of internal iliac artery.
Maybe, but ultimately it's a salvage cystectomy.
Yes, sir.
So before counseling the patient for the trimodal therapy, you have to say that if you go for the radiation, there is a chance of developing radiation cystitis, and you may be cancer free, but over the time period, it may be 4 years, 5 years, 7 years, you may develop a radiation cystitis that may lead to cystectomy. Okay.
Kamal, where is Kamal?
Sir.
When such patient who is indicated for TMT comes to you, what could you counsel him for overall survival or success of this project?
So TMT has been shown to be a survival engine for early stage of the disease. It has got survival advantage during the immediate period of the disease, sir. But
immediate meaning? What do you define immediate?
How many years?
2.
No. 10 years.
10 years.
Oh. 10 years. In the first 10 years. Vikram, do you agree?
Yes, I know the data up to 5 years, sir. But,
No, 10 years.
So 5 years, 50% it was given.
So the overall survival, the TMT is not to be ignored. Overall survival RC is higher than TMT. That is accepted. But pooled data shows no difference between RC or TMT less than 10 years. So if somebody's life expectancy is less than 10 years, you can jolly well recommend this if he agrees to and fulfills the criteria for chemoradiation. Overall survival of RC was higher than TMT at more than 10 years. Cancer-specific survival, RC has had longer CSS than TMT group. This is the article from where I got it. Vikram has got it from somebody else, I think, but whatever. We're all living in a world of survival for surgery, you see. That's the whole trouble. I'm trying to press the point as to surgery is better. TMT is associated with significant increase in all-cause mortality and bladder-specific mortality. TMT meta-analysis suggests that efficacy of TMT is non-inferior to that of RC at less than 10 years. RC is superior to TMT at more than 10 years. And that's the guiding force. If you get a young patient who is wanting to preserve bladder, you see, that's where they want to preserve the bladder. You have to be, if his life expectancy is more, so TMT may be reasonable treatment in well-selected patients who are unsuitable for surgery or not willing to undergo surgery. This is unsuitable is a debatable issue, but not willing to undergo RC is the problem. Propensity score. We understand this. Radical cystectomy, trimodal therapy is better, but in the long run. Unfit patients would meet at least one of the flawing criteria, which Bikram has already said. And we've discussed choice of chemotherapy. Yeah. If eligible for cisplatin-based chemotherapy, offer neoadjuvant cisplatin-based combination chemotherapy patients with muscle-invasive bladder cancer. No, this is a different thing. Yeah. In conclusion, I think we've had a very good Sunday morning. You all guys must be hungry now. My only request is, message for today, please simplify your thought processes about the various entities and the newer modalities like neoadjuvant chemotherapy, lymphadenectomy, in all the theories that have come about. But please don't deviate from the fact muscle invasive bladder cancer equates to radical cystectomy. That's the fundamental theory that you must get ingrained in your mind. When you do radical cystectomy, decide for radical cystectomy, non-muscle invasive, TURBT and follow up, intravesical therapy, BCG therapy, and then it goes into the cycle of being non-refractory and then gets classified into radical cystectomy. When you are presented with muscle invasive bladder cancer, your thought process must swerve towards radical cystectomy, but you must be aware of the options of bladder preservation. In radical cystectomy, the only debatable issue is whether it is neoadjuvant. These are the questions you must answer to yourself. If I am faced with a subject of AVIVA in radical cystectomy, they will ask me about the extent of lymphadenectomy and neoadjuvant chemotherapy. Then you come to two subjects, which is BCG failure and bladder preservation. I think, again, I repeat what I repeated yesterday and this morning. You guys are extremely clever. You're very conversant. You are all going to pass the exam because the standards are very high. Please do not tempt yourself to make a mistake or fall into the trap of the examiner. Answer simple things. The tendency, like I told you in summary, non-invasive bladder cancer is TURBT and surveillance followed by intravesical therapy. Until it gets refractory, you move on to MIBC and refractory NMIBC, which goes into radical cystectomy. And then radical cystectomy, the debates are two, lymph nodes and neoadjuvant chemotherapy. And then if they are not agreeable, then you go on to bladder preservation. I hope we've been able to be of some utility to you. Good luck for your exams and have a nice Sunday lunch. Thank you very much.
Thank you.
Thanks.
Sure.
Hello?